Hello everyone, my name is Wissam Ryan. I'm a fourth year medical student at Chicago Medical School, and this is my FAST exam presentation. This is part of my clerkship in ER ultrasound at Loyola University Medical Center. During this talk, I'll be going through the reason why the ultrasound has become a part of the ER. I'll talk about the FAST exam, then I'll go through how to perform one. I'll also talk about the extended FAST addendum to the FAST exam. I'll talk about some tips for optimizing your technique and getting comfortable with the exam. And then finally, I'll go through some pathologies to kind of indicate what you should be looking for and what you should be worried about. So at first, let's discuss the ultrasound machine in the ER. The ultrasound has become a big part of the ER, not just for traumas, as we see an ER ultrasound, portable ultrasound machine here in the trauma bay, but additionally for all forms of diagnostics like cardiac and lung diagnostics, gallbladder, appendix, OB-GYN, all sorts of other things, soft tissue disorders, joint spaces, effusions, and such. Additionally, you can use it for therapeutic uses like peripheral and central line IVs, especially when doing things like subclavians and intrajugular or internal jugulars. Additionally, you can do centeses like paracenteses, pericardio, and thoracocenteses, which used to be performed completely blind, but now are being performed with an ultrasound machine. That being said, we can start talking about the FAST exam and what it is. So first of all, what does it mean? What is it? Well, it's not something you do on the floor. It is a FAST exam. It's for trauma patients, so we do it in the ER with George Clooney on his TV show. So the FAST exam is a focused assessment with sonography in trauma. That means it's not FAST as an adjective. It is an acronym, and it's not to be confused with the RUSH exam, which is for hypovolemia. This is a completely separate entity. So why is the FAST exam such a big deal? Well, the FAST exam is important because you can pick up as little as 50 milliliters of free fluid in the abdomen or the pelvis. Normally, an amateur or someone who's newly starting out with the FAST exam will need about 200, 250 milliliters of free fluid to notice something or to get a fully positive exam. But a trained physician or tech can pick up as little as 50 milliliters of fluid, which, as you can see on this graduated cylinder, is really almost nothing. Additionally, in a 62 publication analysis of 16 or 18,000 patients, we see that we have an 80% sensitivity and 99% specificity for various pathologies picked up during a FAST exam. Now, if you simply remove all physicians other than ER physicians, the sensitivity will go up to 90%. And then if you hone down to certain pathologies, like pericardial effusion, for instance, you get your sensitivity almost at 100%, which is phenomenal. Now, a lot of people will counter that argument and say, I've got a CT machine in the ER, why do I need the ultrasound? Well, the ultrasound's a lot faster. It takes 2 to 4 minutes to perform a full comprehensive FAST exam. If you feel worried, if you didn't pick anything up, or if you're concerned about the validity of your results, you can repeat it to increase your sensitivity. Additionally, you can do it while performing resuscitation on a patient, while putting in IVs, checking for all other forms of damage, fractures, and such. And the machine itself is portable, so it can be brought into the room or relocated if need be. Finally, there is no consideration for renal issues because you don't have to give a patient contrast, and you don't have to wait for them to drink contrast before you perform a CT. But alas, nothing is perfect. We do have issues. There are 3 main issues. We have the etiology issue, which comes about because we can see the free fluid in a FAST exam, but we don't necessarily know where it came from or why it's there. This can be problematic, but is oftentimes fixed by continuing through the algorithm that I will discuss in a few slides. Additionally, obese patients or seizing patients, combative, intoxicated patients can cause a lot of problems when trying to perform such an exam. And finally, you can't really see the retroperitoneum very well, and therefore you end up needing a CT scan anyway with a lot of these patients. So when do you perform a FAST exam? Well, obviously the T in FAST stands for trauma, so you perform it on trauma patients. It's part of the primary survey. It can be done while performing resuscitation, and there is a pretty good algorithm for when to use it. This is the full algorithm, but I like to stick to the reduced one, in which I remove everything except, in my opinion, the bare essentials. So if you follow this algorithm, you can take a standard trauma patient, determine if they're stable or unstable, and then perform the FAST exam. If you get a positive finding in an unstable patient, they need to go to the OR emergently for a laparotomy. If they are stable, even with a positive finding, you can take the time to perform a full CT scan. So that being understood and knowing how to run through an algorithm, now we can learn how to perform the FAST exam itself. So the first thing is to get equipped appropriately and be prepared for what you're going to have to go through. The two main things are probe selection and, of course, getting your ultrasound gel. Probe selection comes down to two main components. It's resolution and penetration. You want to be able to see things clearly, but at the same time, you want to see deep enough. And these are indirectly related because they function as proportions to the frequency of the waves coming out of the ultrasound probe. For instance, if you have a very high frequency probe, such as like a linear probe, which is used for very shallow applications, you can see things very, very clearly. The issue there is you can only see up to 3 or 4 centimeters down, which is not very useful. Sometimes you can get up to 5, but still, in even a partially somewhat obese patient, you really can't get in a very deep view. Additionally, if you need to increase your depth, you want to drop your hertz to a much lower frequency, and the trade-off there is resolution. Sometimes you get very grainy images or dark images. So when performing something as essential and critical as a FAST exam, we want to use the best blend of these two. And that comes down to probe selection. So these are the 3 standard probes that you're going to see on most portable ultrasound machines. You have the phased array, the convex, and the linear. When performing a FAST exam, typically you'll find either the phased or the convex probes are used. A more skilled technician or a very skilled physician will end up using the phased array probe because it has a smaller footprint and allows you to wedge between ribs to eliminate rib shadows and get a clearer view. The convex probe has a nice wide footprint, so it's really easy to learn with, and it gives you very deep views because of the nature of the way the crystals are aligned in the probe itself. The linear probe is what we typically see for procedural things and will be discussed a bit later. Before you make your final move and get in the room with the patient, you want to make sure you set up your machine appropriately. So you want to put the abdominal exam so you're not going to be in a cardiac exam or OB exam mode when you go in there to try to FAST a patient. Additionally, you want to line up your markings on your screen. The marking takes a bit of getting used to, but once it's there, it's extremely helpful. Each probe will have a mark that you can typically feel when holding the probe. I have it circled here on a linear probe, and this allows you to orient the mark with a dot or a logo on the screen. Here we have a green dot on a corresponding ultrasound screen. Oftentimes you'll see a letter or a logo. It's usually a brand logo or the first letter of the machine name or something that indicates what alignment the probe is going to be with the screen. If it's in a location that you don't like, there's usually a toggle button somewhere very easy to find on the machine that you'll keep pushing until it circles around to the location you want it. And the way this helps is with the alignment of procedural things like biopsies and needle insertion, as well as identifying structures such as the right versus the left part of the heart, etc. Here we see the dot is on the proximal side of the needle at the top, and on the bottom we can see that the logo or the green dot on the screen is also lined up with the proximal part of the needle. And this is just a brief example of how important it is. Finally, you got to remember that fluid is black and dark, and organs are not. So when you are performing a FAST exam, if you see a floating organ, it's typically a very bad sign, because that organ is surrounded with free fluid, which is something you don't want. And now it's time for the FAST exam. We have 4 components, 1, 2, 3, and 4. The subxiphoid and cardiac views would be the first one here. Number 2 is going to be your right upper quadrant. 3 is your left upper quadrant. And then 4 is your pelvic or suprapubic view. Finally, take a breath, be calm, and take your time when performing the exam. If you rush through it, you won't find what you need, and you are very, very likely to miss a finding. So let's start with the cardiac or the subxiphoid view. A lot of people will start with this view just because you don't want to miss a cardiac tamponade and effusions, so you want to kind of start with those. Here we see an animation that shows you the best approach for a subxiphoid view. When performing a subxiphoid exam, you need to flatten your probe quite a bit and push down below the ribs. You will feel like you're hurting the patient, but it's important to push just to make sure the rays don't catch the ribs and they get under. As you can see in the animation of the exam, once you push down, you're going to be using your liver as a window. That means your rays will pass through the liver, then go through the heart. So the closest thing on your image will be the liver. As you can see here, we have another animation, or a recording actually, of a normal subxiphoid exam. At the very top of the screen is the liver. It's being used as an acoustic window, and then you have a functioning heart. When performing this exam, you see these bright white lines that were just outlined in green. That's your pericardium. If that is lined with black, dark black, or you see black slivers around it, that's the beginning of a pericardial effusion, and that's something that you need to be very aware of and prepare for a centesis, or at least diagnose it appropriately. Additionally, you want to make sure you're oriented properly. Here we see the right heart on the top part of the screen and the left heart on the bottom part, and it's very obvious because the left heart has really thick tissue surrounding the left ventricle, whereas the right ventricle is very thin, which is what you would expect in a normal human being. Some people will incorporate a peristernal approach, which is kind of like a stabbing maneuver. With the probe, you take the probe and push it down directly in, holding the probe almost with a fist, like you're getting ready to cut someone. And it's almost in the mid-clavicular line, not necessarily so. It's going to be a little bit left of that. And you're going to kind of try to wedge your probe between the ribs so you can get a nice angle. The issue here is that you're going to be needing to sweep quite a bit to catch the entire heart and make sure you check everything. When performing a pericardial exam, or a peristernal exam, this is the kind of image that you will see. It's very different. You don't have the liver as an acoustic window, and you get a much more obviously sagittal slice of the heart. What you'll want to do then is twist the probe 90 degrees after sweeping the entire heart and catch a transverse cut of the heart. Here we see the left ventricle, which has got this nice thick donut look to it, and the mitral valve, which is the only bicuspid valve in the heart, beating very regularly. The thing you want to look for and be careful for here is the effusions. Again, you want to sweep the entire length of the heart, or the entire width of the heart. And additionally, you want to make sure you're not catching or missing any flattening of the heart. Typically, the right heart will flatten before the left because of the pressure difference, and that's a very bad sign. The next component of the exam is the right upper quadrant exam. What you want to do to begin the right upper quadrant exam is push the probe against the patient's right side, go about halfway up their torso, so you're about to ribs 7 through 9, and you want to angle it down like you see in the animation. The angling does two things. It gives you a little bit of a window through the ribs. Additionally, it kind of catches the kidney with the liver, which is exactly what you're looking for. When you angle the probe like that, you want to see 4 things. You want to see the Morison's pouch, which is the hepatorenal space, which is indicated here. You also want to see the tip of the liver, and you want to see the diaphragm. The 4th thing that you want to see is the full span of the liver. And I don't have that listed here, and I don't have an animation of it, but what you need to do is sweep through the entire liver just to make sure you don't miss anything. Moving on from the right upper quadrant, we go to the left upper quadrant. There is quite a bit of difference when performing this exam after the right upper quadrant. First of all, you need to be against the patient's left, obviously, but you need to be a lot more superior towards their head, a lot more superior. You need to have your probe a lot more posterior as well. So basically, you're almost going to be hugging the patient with your right hand knuckles touching the bed, basically, because you have to push down and shoot upwards almost through their back to catch the spleen with the kidney. So what are we looking for here? What we'll be looking for here is the splenorenal interface, which is the interface between the spleen and the kidney. We also want to see the tip and the base of the spleen and the diaphragm. So here would be the base of the spleen, as you can see in the little animations frozen image. At the bottom right corner, you can kind of see a diagram of what you're looking at. And then off all the way up, if you sweep all the way to the top, you'll see the tip of the spleen. You can still see the kidney the whole time. And then finally, you need to make sure that there's no pleural effusion, so you got to look for the diaphragm. Finally, the last part of the FAST exam is the pelvic exam, or the suprapubic, or the bladder. People call it different things. It doesn't matter. Just make sure you look down there. This is a model of a female exam. There's not much difference. You perform them both the same way. You want to do a long and short axis. The only difference is you'll see an ovary. You'll see ovaries and a uterus in one, and not in the other. Here, it kind of indicates. It kind of shows how to perform the exam in the animation. The thing that you don't really get from this is how low you have to be on the patient to catch their bladder. It's when you feel uncomfortable, when you start feeling uncomfortable pushing the probe low and getting closer and closer to the patient's private area, that's about the time when you'll start to see the bladder on your screen. You should really just feel for the symphysis pubis and then push the probe about 2 centimeters above that, and you should be fine. Additionally, you kind of have to angle down towards the sacrum and put a bit of pressure on. What are we looking for when we do this exam? Obviously, the bladder. We want to make sure there's no free fluid there. If you're looking at a female, you want to look for the uterus, ovaries, and in a man, you should see a prostate. Okay, so now that we've gone through all that, I think it's about time to do a quick review of just what we have looked at. We need to remember that there are 4 components to the FAST exam. So here are our 4. Positions 1, 2, 3, and 4, the subxiphoid, right upper quadrant, left upper quadrant, and then the suprapubic. And these are the angles that you should kind of be looking at. Remember, with the subxiphoid, flatten the probe, get a nice acoustic window through the liver. With the right upper quadrant, for the peristernal, you want to do kind of a stabbing motion. Make sure you're a bit between the ribs, and don't be afraid to twist your probe to get your raise to really lose some of that rib shadow. With the right upper quadrant, you want your probe to be as parallel as it can with the bed, a little bit superior, about ribs 7 to 9. With the left upper quadrant, you want to be significantly higher. Ribs 5 to 7 should be pretty good. Almost having your hand in the patient's armpit, knuckles touching the bed, and really angling upwards from the back to the front. Finally, with the pelvic exam, uncomfortably low is the easiest thing to remember. Go to the symphysis pubis, be a couple of centimeters above that, and push down and really angle the probe to find what you're looking for. So now let's talk about the extended. The extended FAST exam is not as extended as you might think, so don't get butthurt. It's only a couple minutes, if even that, longer, and then you can go back to sleep. So the extended FAST is important because when picking up a pneumothorax, it's a lot more sensitive than a chest x-ray. It's a lot easier to do because you're already in there doing a FAST exam. You don't need to bring in the entire portable x-ray machine. And even when diagnosing a hemothorax, it's just as sensitive as a chest x-ray. So it should not be avoided, and try not to forget it. It should actually probably become a permanent part of the FAST exam. So again, how do we equip for the extended FAST exam? This is the only time you should be changing probes. You'll go from whatever you're using before, the phased array or the convex, and switch to a linear probe. You want to be a lot more shallow. You want to have a lot higher resolution, and you need a nice small footprint. So that all makes the linear probe perfect. You're going to be performing the exam a bit similar to the parasternal exam, except of course you have to do both sides here, left and right. You want to take the probe and place it up against the chest, and you want it to be longitudinal so you do catch the ribs. And the importance there is that they're nice landmarks, because you get two shadows coming off of it to give you a nice indication that you're in the right area. Additionally, you want to be mid-clavicular, and you should probably check more than one area to make sure you're catching any anterior or posterior or inferior pneumothoraces. So what are we looking for? In this video, you can see this white, well now green highlighted white structure sliding. Those are the lungs sliding against, the lung pleura sliding against each other. This is a normal exam. As a patient breathes, you should see the sliding motion. If you don't see that, that's when you start to get concerned. If you switch the mode to the M mode function, you'll be looking for something called waves on the beach, which I'll discuss later. So that completes the extended portion of the FAST exam. So now let's go through some tips to make sure you're doing everything to the best that you can. First thing, flatten the bed completely. A flat bed is going to really help with body habitus. Even bigger patients will be a lot easier to visualize when the bed is completely flat. Additionally, it makes the patient more comfortable and so forth. The ribs will be pulled out of the way by the stretching motion, and if that doesn't happen with this and you're still catching a lot of rib shadow, what you want to do is basically ask the patient to do a backstroke. When you're doing the corresponding exam, you'll have them pull up their arm almost like a backstroke motion and just leave it there. Sometimes you may have to lift it for them, and sometimes you may have to avoid this because of patient's pain. For instance, if they are an MVC patient and they have shoulder pain or a dislocated shoulder or a broken humerus, you really don't want to do this to a patient. But in the event that you can, this helps a lot by pulling the anatomy in a direction that will really allow your probe to get around there. The next thing you can do is ask the patient to take a deep breath. In this image, you can see that the diaphragm is going to contract downwards as indicated by the arrow. So basically, tell the patient to relax, ask them to take a deep breath and hold it. The diaphragm will push everything down and stay there. Just remember to let the patient know that they can start breathing normally again, or else they'll hate you. But for the most part, this helps the most out of all the tips that I've gone through, or out of the other tips I've gone through. Finally, if you're getting lost, can't find anything that you're looking for, remember to do a sweep. When you take a sweep, look for landmarks. This is especially useful when looking at the kidneys, the right upper or the lower or the left upper quadrants. Sometimes you'll miss the kidneys, so if you do a quick sweep, you'll catch one portion of it, and that'll help you orient your exam. Finally, check your depth. Remember that there's a depth option, or there's a depth number that you can toggle on your machine that allows you to see upwards of 26 or almost 30 centimeters in an abdominal exam mode, or 4 to 6 centimeters when you're doing a linear probe exam. When you're looking at the thorax, take that number, set it down to about 4 centimeters. When you're looking in the abdomen, set it to about 16 to 20. Really, this varies based on patient's body habitus, but most patients will be fine with about 18 centimeters, even some of the bigger ones. And finally, let's avoid these next problems. You really don't want to be doing an OB exam on a man. It's not going to make that big of a difference since most of it is calibration, but if you're trying to do a cardiac exam in the OB mode, you're not going to see anything. So always remember to just check your mode if you're really not seeing what you're looking for. Additionally, don't be shy. You really need to use the ultrasound gel. If you have air in between your probe and the patient, you're not going to see anything, or you're going to get a lot of artifact and interference. So use adequate ultrasound gel. It's cold, it's annoying, and it's gross to pull off the patient afterwards, but it is better for the patient and better for you ultimately. Additionally, you're going to have to push the probe into the patient. This is most important for the subxiphoid exam and the pelvic exam, really. The pelvic exam, or the suprapubic exam, is most easily accomplished when the patient has a full bladder, which is really unfortunate because you also need to push into the patient, and it's really going to make them want to pee. So do it last, and make sure you warn them. Additionally, when you're doing the subxiphoid exam, make sure you're mindful of the patient's chief complaint. If they're in there because they have abdominal pain, and then on top of it you're pushing, you're really going to piss off somebody. So make sure you know what you're dealing with and where the pain is on the patient before you push, but don't be shy. You really have to, otherwise you're going to get in trouble because you're going to miss something. So finally, we've gone through everything. Now, what are we actually looking for? So the problems come about in the following situations. When you're looking at this subxiphoid, this is a normal exam with the right heart labeled properly, the left heart labeled properly, and this is what you don't want to see. The asterisk is showing you a pretty moderate to mild to moderate pericardial effusion, but the issue here is a complete flattening of the right ventricle. You don't even see any real fluid kind of filling into there. That's indicated by the arrowheads. This is a bad sign. So if you see this, you should be concerned. This is one of the things that you're going to be looking for. On the right upper quadrant, we have a normal image here with the liver, very good, very clear indication of the diaphragm. You can see the pleura, the kidney, and the interface and Morson's pouch. Here we have a nice floating liver. Also not exactly an ideal exam. This is an individual with severe ascites. Their liver is floating in free fluid. This is an indication for workup and centesis and all sorts of things. Here we have our left upper quadrant. When you're looking here, remember you're looking at the spleen and the kidney. This is really important in MVCs and patients who have had mono, et cetera, any case where you may lacerate the spleen, because there's so much blood flow going through there, you can really cause a big problem. So you really want to make sure you catch the very bottom tail part of the spleen. Basically, the interaction between the spleen and the diaphragm is what you really want to see, because that's very dependent, which means when a patient is laying down, fluid will pack up and hang out back there. Here we have the arrowheads showing you the diaphragm. PL is indicating the pleura, and the asterisk is free fluid. So the free fluid is between the spleen and the diaphragm, which is basically what I was just trying to explain. Finally, in the pelvic view, here are the male images that I promised. We have a bladder, we have the arrowheads showing you a prostate, and then we have the rectum below that. And this is a transverse view, obviously, because you have symmetry coming down the middle. In these images, you see an interesting pathology. You have the bladder at the very bottom. The arrowhead is showing you free fluid gathering, and this darker part of the free fluid is just a clot. So clearly we have bleeding in there that's starting to clot up, which is a big issue. So when you lose your symmetry in the pelvic view and things like that is when you really want to start to get concerned. Finally, in the thoracic view, we have these images. This is the only time you really want to switch your probe again, remember, to the linear probe, and this is where you have to look at your M mode. On the left side of these two images, you're going to see this thick white line. That's your pleural interface where the pleura should be sliding against each other. If you push the M mode button on your machine while doing this exam, you're going to see straight lines at the top, which are the C or the waves, and this speckled interface at the bottom, which is the shore. This is why people say C in the shore or the waves on the beach or whatever. This is normal because at the top nothing is moving, so you get straight lines, and at the bottom there's the sliding of the lung against the pleura, so you get this kind of shore look. When you run into a problem is when you see this. These are called the barcode or the stratosphere signs. Basically, nothing is moving. At the top of the screen, you can see a thick white line, that's your pleural interface, the two black dark shadows on the left and the right. Those are your rib shadows. Remember, we said we want to use the rib shadows to align ourselves and make sure we're looking at the right thing. At the bottom, you should be seeing the waves on the beach, but this patient is inhaling and exhaling and nothing is happening, and that's an indication of a pneumothorax. So finally, we've gone through everything. I hope I've answered all your questions, and I hope I haven't confused you anymore. The most important thing, again, is to be calm, relax, take your time, and do as many as you possibly can. With repetition, you'll get a lot better, and you'll start picking up little nuances that are going to help you get better as a physician as well as a technician when performing the exam. Special thanks to Loyola University Medical Center for hosting this clerkship, and I'd like to thank Dr. Lee and Dr. Lees and Dr. O for being great mentors. Thank you.